That's my cloud guy calling.
All right, good morning, everyone. We are now live. This is the Health Reform Oversight Committee meeting of December 4th. It's still 2025, looking at the end of the tunnel for this year. But this morning, we're looking at some elements of work as a result of the policies that we've passed through legislation. And I think it's really important that folks understand how hard we have been working to understand the healthcare landscape, how to improve it across the state, how to make it accessible for patients, how to make it affordable for everyone, and to improve quality as we're going along. The work that we're looking at this morning actually begins with a grant application that is motivated through the Agency of Human Services. And it will be important for us within HROC to understand how that grant fits with the system changes that we've been looking at since 2022 and probably before, with Act 167, Act 51, Act 68, among others. So I would just like to, I'm going to stop talking. I'm going to say we have a very full agenda. We, as committee members, are going to be filled with questions. I'm going to ask that we write all of our questions down. If we can get into a discussion after each presentation, we'll do that. But I know there's a lot of work that we'll be doing in our individual committees once January gets to us. And so we are looking for details. We're looking for boots on the ground. What is happening? Who's doing the work? What more do we need? And how can we improve our system of care throughout the state? I know it begins with hospitals, goes to EMT, goes to community-based services across the board. And it's all to help people. So, Vice Chair Black, would you like to say anything?
I'm sorry, I hadn't prepared anything, but thank you everybody for being here. I'm looking forward to updates on all of this.
Terrific. That's good. We're good. We've worked hard on putting the agenda together, and I know that you've communicated with Nolan and Jen and Sorcha on this, each of you who are testifying. So why don't we go right to the Rural Health Transformation Program grant application. Jill and Sarah, you're both here, so for the record, for being here.
Thank you for having us. I'm Jill Mazza Olson. I am the State Medicaid and Health Systems Director. I've been in the role about 2 months, maybe 3. I don't know. Time is flying.
And good morning. For the record, I'm Sarah Rosenblum. I'm the Interim Director of Healthcare Reform at the Agency of Human Services, and I've been in that role for maybe 3 or 4 months.
15 minutes longer than me.
Yeah. Thank you so much for having the Office of Healthcare Reform and our staff here today to speak with you. I will note just on this title slide, we include Dr. Craig Jones. Unfortunately, Dr. Jones is not able to be with us this morning, so he's listed on this slide, but you won't see him today. Otherwise, you'll see a number of members of our staff. And on the next slide, so we're speaking, as Chair Lyons said, we're going to start with the Rural Health Transformation Program update. And then we're also, representatives from the Office of Healthcare Reform are also going to talk to you today about Act 167 and hospital transformation. I just want to say at the outset that these two topics are related, so it's a good thing that we're talking about both of them today. I think everybody in this room probably knows that, and Chair Lyons spoke a little bit about this in her intro, that the Act 167 hospital transformation work has been years in the making and is still ongoing. And the Rural Health Transformation Program is a new opportunity that hopefully will yield some funding for us to continue that work and to bolster it financially. So with that, I will turn it over to Jill to talk more about the Rural Healthcare Transformation Program.
Great. Thank you, Sarah. It's good to be here today. This is my first time in committee in this new role. So I'm really glad to be here and to share more about this program with you. When I started at the agency, this was just being launched by CMS. And I think you probably already know, we had about 6 weeks from the time it was released until the time it was due. And so there was a team of people working really fast to put this application together. And I think what's really helpful is that Vermont has done so much healthcare reform work over time that we were really able to leverage a lot of work that's already in place, either things that we wanted to modernize or things that we wanted to scale up. So we didn't start from a blank piece of paper. The funding opportunity for states is up to $200 million a year for 5 years. So we have, and there's sort of it's actually in a different slide, realizing these are maybe not in the order I'm talking in. There is baseline funding, that's $100 million. And then there's what they call workload funding, which is the second piece. And we expect that all states are going to get that baseline funding. That's how we understand it. And then there will be scoring related to that workload funding. So we don't know how much the total budget will be in the end. We expect to know between now and the end of the year. So that's coming. There are many, many initiatives in this grant. You can go to the overview slide. And so part of what I think I need from you is I'm going to need a little bit of guidance on where you want me to go into some more detail, because I don't think I can do all 40 odd initiatives in the time we have. Just saying. I'm a fast talker, and so I'm going to give you a bit of an overview, and I want to also just share with you the materials that are available to you and to everyone else. So that as you want to look for more questions and think about where you want to hear more, you can. So already on our website is the entire application. So that's a very long document, 70 pages.
I think you've sent that to.
Yeah, you have it.
Yes, we have it.
Yeah. So you have that. You also have, there's a very high level summary on the website. What we did for today that's new and that will be, I expect to put on the website is this document, which is a table of all of the initiatives. So this is for the detail people who don't want to read the entire 70-page application.
I appreciate that.
This is a list. This is a list for the list people.
Darn, I wish I'd
Yes.
known that.
So I am a list person. I'm one of the list people. For the list people, this is for you. So this is, I think, going to be a really helpful reference point for all of us. And of course, as we negotiate with CMS and figure out which things are in and which things are out, this is a document we're going to need to be updating. But I was hopeful that you would find this helpful, even maybe if not in this moment, after the fact. And also, I think for our community partners, I think this will be a useful document as well, to just help people understand our thinking. So, big picture. I'm going to go out of order on that slide. I'm going to start with workforce. And the reason I'm going to start there is because this is an area where we had done a ton of work already. Lots of stakeholder engagement. We have a workforce subcommittee that was created by the legislature that's been working for years to try to come up with a workforce strategic plan. And so when we set out to create this proposal, we built off the work that group was doing. Page 7 of this. Thank you. So it includes, there's one thing that's, that's new. I'm going to hold on that for a moment, but many things that I think will be familiar to many people in this room. So essentially it is opportunities to train clinicians of all types on site in clinical settings. So in nursing homes, in hospitals, in home health agencies. And those are those kind of preceptor programs where there's clinical trainers on site and people being trained on site. There is tuition assistance. There is, all the tuition assistance comes with 5-year commitments to Vermont. So it's building on, VSAC has had a program for a long time. I think it's focused just on nurses. They call it a loan forgiveness program, but it's essentially a program whereby if you complete the program, you complete your service, your required service, you incur no debt. If you don't complete your service, you have to pay the loan. It becomes a loan. So it's called loan forgiveness. Loan forgiveness of existing loans is not allowed under this grant, but we think this kind of model is allowable because it's really, the loan piece is really to create the consequence for people who don't meet the service obligation that is a part of this. So that is, and then we're also hoping to relaunch the critical occupations no-cost tuition program that existed, I don't know, maybe 3 years ago. So these should all be familiar things. Also here is the Maple Mountain Family Medicine Residency Program that I think people have been talking about for a long time, wanting to launch. So we're hoping to get funding for that. So those are all kind of, I think, pretty straightforward programs. The one thing that's under workforce that's more unusual is workforce housing. So housing is a priority for, I think, all of us in many ways. I'm going to say right now, housing is definitely not my area of expertise. But this is also, of course, a priority for the governor. And so what this would do is mirror what's called the VHIP program. So it mirrors that program where it provides funding for developers to rehabilitate existing infrastructure for housing. And then the sort of the obligation is that the people who use that housing have to meet certain criteria. In this case, it would be the healthcare workforce. So it would be people who work for some kind of allowable organization, a hospital, yes, but also a home health agency, also an FQHC. So this is entirely brand new. It's not something that exists now, and we don't know what will happen with this idea. I haven't seen this in any of the applications from other states that I've reviewed. I've been sort of making my way through some of them. So we'll see, but that is the concept here. More development work to do. It would not go into effect quite right away because we'd have to do a little more work, but we have a model to work from.
And there are a lot of questions about this, so I'm feeling them around the table as much.
Okay, we may have to take them back.
No, just keep going.
Okay,
And as I said, write your questions down, but there are some significant policy issues associated with a number of things that you've talked about.
okay.
What do we need to do to have any of this go forward, and how does it affect other programs? So those kinds of things surface as you're talking.
Yes, yep, absolutely. Okay. I'm going to talk about technology. So technology is a strong theme in the NOFO. It was something that they really wanted to see us apply to use technology in new ways. And so we have a number of different initiatives that have a technology component, I would say. And so one of them is we've heard from many hospitals, not all hospitals, many hospitals, that they're interested in actually using a shared electronic health record as a way to create interoperability. So I just want to pause here because this creates anxiety. One, this is not a mandate. And it's definitely not a mandate for community providers for whom the EHR, the electronic health record that a hospital might not work for example, a home health agency. People who are doing charts on tablets in their cars. Might not work for a primary care practice. So it might not work for everyone. There is no intent here to try to force anybody into a different EHR than the one they're in. It's meant to support something that we're hearing from our hospitals that they're interested in doing. So I just want to be really clear about that. Another is to support remote patient monitoring technology. So that's technology in the home. Home health agencies use it, primary care offices use it. It's not really funded in any way, but it allows for patients to provide important clinical information about their chronic conditions to a clinician who's paying attention. And it's a very good tool for preventing hospitalizations. It can catch things long before that people are aware that they are in trouble. So we want to do more of that. Closed loop referrals. So that is basically a system where that brings information when a referral is made. So let me back up. What happens sometimes in primary care is that people make a referral and then there's no clarity about whether the patient followed through on the referral. This is it's closing the information loop. That's the closed part. It's closing the information loop. There is interest in supporting AI transcription for providers for whom that's going to be really expensive and prohibitively expensive. So that's another piece. And then there's also, I would put under here, actually, I'm realizing it's not on this slide, but there's a whole e-consult section. So that's really a clinical and a technology idea, but it's a way to have electronic consults from specialists out to rural communities. This is a really important strategy for getting specialty care into rural places. It would also include there is a child psychiatric care program in place already in Vermont, which is going to run out of funding. Our intention would be to use this money to extend that, so that we added that to the application. I think that's the big picture on the technology. On the planning. So, and just, this is actually, I just want to say one thing. These are not exactly the way that these are laid out in the application itself. This is sort of my how I think about it, like sort of how to bucket the ideas. So planning. So one is we want to explore some strategies for expanding our insurance options and exploring potential for reinsurance for the marketplace. So really important initiative. And so this would not do this would not create reinsurance. This would explore reinsurance, but it would allow us to do that. It would create some additional consumer-facing price and quality transparency tools, housed, I think, at the Green Mountain Care Board. And really, this is also partly to sort of help support the data infrastructure at the Green Mountain Care Board. That's all kind of wrapped up into one piece. And then more data and expert support for regionalization, some of the work that we're already doing. Okay, now I'm going to go back up to the strengthening the networks. So lots of things on here. Many of these are scaling things that exist today, but expanding. I'm going to skip primary care for a moment because there's a lot to say about that one. So some of the things we want to do is better support the communication for transfers of patients. So there are subscription models in other places that help create better information so that people know where the options might be. So supporting transfers. We want to enlist EMS in a new way. So we have some community paramedicine or there's a couple words for this. Thank you.
Healthcare.
That's the one I can never remember.
Or MIH.
Do you see how quickly Sarah knew I was not going to get there? Thank you. And the reason we're interested in that is because sometimes the EMS workforce actually is a clinical workforce that has time. Most of our workforce does not have time. The EMS workforce sometimes has time. And so we want to enlist them in a new way and also provide them with, some of this is just really a payment reform idea, provide them with, they don't get paid if they don't take you to the hospital. There's a lot of places we might want EMS to take you, or we might want them to take care of you at your house. And they only get paid when they drive you to the hospital. So that is not in alignment with our what we want. So that is I think this is a really exciting thing. This is going to take this is an area where there's going to be a lot of, I think, need for further policy development, stakeholder engagement, and thinking to think about how EMS will fit in this way, and also how it fits with existing at-home services like home health services. So there's, I think, a lot of work to do there. Creating new mobile health and dental options. And this is actually buying the mobile units. I don't think I've said this, but this is essentially one-time money, right? It lasts for 5 years, but it's essentially one-time money. So part of our thinking here is we want to use it to launch things. We want to use it to buy stuff, but we don't want to use it to create new baseline funding needs. So I just want to say that is definitely a theme, to not create new baseline funding pressures.
And we can't.
And we can't. And they wouldn't let us anyway.
Yeah.
Yeah. But we agree. Yeah. Good. Thank you. Building out mental health urgent care, something we know we need more of in Vermont. Expanding access to complex care in nursing facilities. So that means like dialysis or ventilation units in nursing facilities. We have very little of that. People are getting more and more complicated. And their healthcare needs are getting more complicated. expanding recovery housing, which is something that already exists in Vermont. Pharmacy test to treat. So this is another one that's going to require some clinical input. Are there any doctors in the room? They all get a little anxious about this, I've observed, about pharmacists providing care directly on site. So this is something that we're going to need to do some more work on, but the idea is you get tested for strep throat at the pharmacy. They treat you right there. That's the concept. Obviously, people start getting worried about, how are we using our antibiotics and our stewardship, all of those things, but that's the concept. Now I'm going to go back up to primary care. So the Blueprint for Health is Vermont's really groundbreaking primary care enhancement program that started back in 2005. We have an expert in the room on the Blueprint, so I will not pretend to be the expert. I was at the press conference when the Blueprint was announced, which makes me feel unbelievably old. And actually, what's funny, I'm going to just tell the story. What I remember about the press conference is Dr. Paul Jarris, who was the health commissioner at the time, trying to explain about how we needed to support physicians, mostly related to diabetes, in understanding who had a hemoglobin A1C test recently, just essentially taking their panels and understanding how they were doing and proactively thinking about patients who needed outreach. And the media in the room struggled to understand what he was talking about because they weren't actually aware of the problem. They thought that was the solution. Surely we already had that. It was very, very interesting. I've never forgotten it. So the idea here is to, I think you really will need a subject matter expertise to really go through the entire proposal. And this is one where I think we're going to need a lot more engagement as things get developed. So I just want to be clear, this one is not fully baked. There's a lot more engagement work to do. But some of the big pieces, going to my little notes here.
Page 7.
Well, it's a little before that. So page 5 even. So some of it is PMPM payments, so per member per month payments to support the community health teams. But part of that will be to as I understand it, part of the idea is to think about whether we need to have more consistency between community health teams. This is a big deal because they've grown up kind of individually in their communities. But to have some of these payment models require some more consistency. So to try to work that through is one of the concepts. The mental health integration, that's something we're doing now on a pilot basis. The money's going to run out. So we asked to have it continue using these dollars. Let's see. Other things I just want to highlight. So yeah, supporting the community health teams. Oh, and then creating some potentially shared payments between primary care and specialty care, some shared incentive payments. And then we're calling it primary PMPM capacity payment. And that's really to try to create capacity for longer hours, so more access to primary care through things like longer hours. Those are, I would say, and more analytics. I think those are the big ones. So again, I am not the subject matter expert, but that's the concept here. And again, more stakeholder engagement here is required. And we do have the primary care steering committee, and there's the Blueprint committee. There's all kinds of mechanisms already in place where I think we'll be able to do that work. Okay. Let me see what else. What did I not say? Anything really important? I think I've covered most things.
Yeah.
Okay, I'm going to pause there.
Can I make one point before we?
Yeah. Yes.
I just want to, Jill spoke about this a little bit. We talked about the $200 million. We talked about the content that's on slide 7, about that there's 2 different buckets of funding, one $100 million bucket, another $100 million bucket. We don't know how much money we're going to get. I will say, I think this is an important point as folks are, for example, reading the whole application or reading the whole chart new document today, which is that we were required to submit an application that aligns with a $200 million budget. If our application is approved, which I think we're all hoping it is, we will have to go through a negotiation process with CMS that aligns with the budget we are actually awarded. So as folks are digesting the application, keep that in mind. You know, it's developed with a certain budget, and that's not the budget we will necessarily be awarded, and therefore we'll have to make not necessarily everything is going to be implemented as written in that chart.
Yes, that is really important. Yes, we don't know what will be funded yet, and we don't know which programs they'll approve. So there's a fair amount of work that's going to probably happen, I don't know, Christmas Day to to try to, I've warned my family. Yeah, could happen. To try to sort out what is in and what is out and what to do next. So, yeah.
Okay, thank you. So, go ahead.
There's one other thing I left out. I'm realizing if we go to slide eight.
Page 8.
Yeah, the one thing you asked us in one of our pre-meetings. So in terms of any related legislation, so I don't think we need any legislation this year. Let me start there. But a couple things I want to highlight for you. So one thing is that the NOFO did have a series of policy initiatives that states that are part of the scoring. So, and you had to have those things in place essentially before making the application. But one of the things we did do is reviewed all of them to see if there were any that were of interest in us pursuing. And the one thing that rose to the top was the potential, and this is not a decided thing, but to pursue the SNAP waiver that would prohibit the purchase of non-nutritious items. We haven't actually started that work yet. We haven't decided to do it. We have just said we're going to pursue it. So this is still something that is a work in progress, but I wanted to highlight it for you as a policy direction that's under consideration. Also not an area where I am the expert, but I wanted to highlight it for you. And then I think the other place where there may be some scope of practice changes to make. So the EMS, almost certainly. And then the pharmacy test to treat is probably going to require some legislation. And then we're also pursuing a policy change. This is a waiver to opt out of, there's a Medicare supervision requirement for CRNAs. So that is the certified registered nurse anesthetists.
Yes.
Yes. Okay. And so there's a supervision requirement. So anyway, that would, many states have opted out. So we are in fact pursuing that now. None of these things should, whether or not we are able to get to the finish line on these, should change the outcome of the application, because you had to have had things in place before for the scoring to happen. But you asked me to highlight for you anything where we might be asking you for legislation, and here it is, but it won't be this year.
This is good. I know there are questions around the table. Representative Black has a question. I have several. I'm going to save many of them for when we get into the session. I'm glad that you mentioned capital costs versus operational. So that's important for us to all know. We're not trying to open up a whole new program for 100 years.
Yes.
The other thing that I feel critically important for us as legislators is that when we pass 167, 51, 68, and others, all of the things that you have talked about, and then some of the proposed policy changes that you're asking for are in that legislation. And it's something that we have all agreed upon. So I don't want us to walk away from this meeting thinking that this Rural Health Transformation Program is a brand new world for Vermont. It isn't. It is a reinforcement. It will take money and put money up front so we can kickstart, get the motorcycle going and get down the road. So I want to be very clear about that. Because frequently we forget the work that happens between January and May. And today we're not forgetting that. That's why we're here. So, and I thank you for your work. It's been terrific in translating the acts that we have passed and signed by the governor and that you folks are now putting in place. That comment. And there are a lot of questions here. Just so you know, even though you won't be asking for other legislation, there is other legislation. So we'll try to work together on that. I'm going to let Representative Black ask her question and then let others ask a question.
I'm not sure if this question is for you, Jill, Sarah, or Dr. Swan wants to think about it. If he's coming up. So I think I speak for both Senator Lyons and myself that primary care is usually our top priority.
My top priority.
My top
second.
priority. It's always been my top priority. I'm concerned. We set in place this past year, a statewide strategic plan.
Yes.
And what I see I almost see this rural health transformation program as a diversion from where we needed to go in the first place. And it seems as though we're like throwing money at a problem. And in the statewide strategic plan, one of the things that AHS has been tasked with is, what do we need? What do we need? Where do we need it? Has there been an assessment of what an effective system of primary care in the entire state of Vermont, what does it look like? What do we want to see in the future? Where are the resources needed? And are we spending this money to get us to that point? Have we even envisioned what success looks like? Okay, well, you know how I feel about transformation. I'm concerned that, that we have this huge tranche of money possibly coming. And we're just throwing more money into the system. It concerns me. We're trying to shrink the system, and I'm really worried when we talk about like investing in capital, things break. So it's not just a one-time thing.
So let me follow up on that question
Was it
because
even a question?
it's no. It is a concern, and it is a concern that I was going to bring up when we get to the transformation piece. And you can think about it between both of us here at the same time. The concern is that we've asked for an assessment of gaps and needs across the rural parts of the state, across all parts of the state. And do these recommendations fit in with those gaps and needs that have been identified? So we know that the plan isn't supposed to be in place until 2030. That's in the legislation, but maybe we need to move that back a little now.
28.
Yeah, so keep that in mind, because whatever we do now has implications for either keeping the system as dysfunctional or helping it to move forward. And I think that's the concern that we're thinking about. So
Yeah. So I share your concerns. I think you're absolutely right. So we didn't talk about the strategic plan mostly because we were talking about rural health transformation, but there is a relationship, and I do want to talk about it. So the strategic plan, I believe, is actually due in 2028, not in 2030.
yeah, the final report is 2030.
Okay, so I'm targeting, I'm not targeting 2030. I'm not.
No, that's good.
Yeah.
28 is a good.
If I was targeting 2030, my husband would be very mad right now. Yeah. No, I'm targeting much earlier than that. And so where we have started is we've convened the committee, the advisory committee for that group, and we've started an inventory of the different, what I think is so hard in healthcare reform is to get our arms around all the things we're already doing and then so that we can make sense of where are the gaps and what else do we need to do. I feel that, especially coming back to the sort of full healthcare system from like being in the community provider world, I'm a little overwhelmed by all of the different areas. We've got payment reform happening in the Medicaid program. We have our Blueprint program. We have a need to really shore up our long-term care system, which I think is critical. I don't think the state has worked hard enough on hospice utilization. I think that's been a miss for years. Even though I don't work for hospice anymore, I still think that. So I fully agree that we need to inventory and identify gaps and see but what we're doing here with rural health transformation is taking an opportunity and making the most of it with things that we already know we want to do or things that we think are already have potential to be successful. So rural health transformation, I completely agree with you. This is not our healthcare reform plan. This is one tool in our toolbox on healthcare reform. That's all it is. And it happens to be a toolbox that comes with dollars, but we're trying to make those dollars make sense in the larger scope. We did, and this is where there's a direct link. We did, and I didn't say this, I just didn't say it, but there is dollars in here that will also give us some external support for building the strategic plan, just some kind of external consultant, which I actually think we need some help with. We have some funding in Act 68, yes, 68 for technical assistance to hospitals. There's some funding there, but I don't read it that we have this ability to hire sort of some external help. And I think we need some help to help us organize all of this and do some of this assessment work. So I think we're on the same page. And I don't want to allow this to be a distraction from that larger strategic planning work. I totally agree with you.
Thank you.
And I'll just add that I think maybe in some ideal magical world, this opportunity would have shown up in 2028, like right after we wrote the plan, and then
Yes,
we
that
have
would have
this
been
influx
better.
of money. But I think even in that scenario, some of the limitations you're talking about would still exist. Like very much the federal government has framed this opportunity as a temporary source of funding that folks should use for infrastructure and capital investments. I mean, you're right about capital investments and infrastructure investments break eventually. You know, there is a cycle there, but that is certainly a limitation of this funding that exists. It exists today. It would have existed in 2028, even if we had this fantastic plan. It's not a $200 million bucket with no limitations. It has pretty strong limitations.
Yeah, it does.
If we get it.
If we get it.
Thank you. Thanks for coming in and all your work.
Thank you. Woo!
Many rooms are welcome. I'm sure we'll see you again. The other thing I'd say, just backing up, I think it's important for us to remember, if I have this right, the federal government put this program in as a bone to the states because they're cutting Medicaid. And in no way is this going to make up for the losses that we are going to experience in Medicaid. So while this is nice, there's a dark side to what it is we're talking about here. And I think that needs to be acknowledged. And I'm wondering, so what aren't we going to be able to do? What aren't hospitals and other places be able to do because of that change? I don't know if you guys are the ones to answer that or somebody else, but we need to not forget that.
Yeah, so you're going to hear later from our subject matter expert on what's happening with eligibility. And of course, what we're dealing with right now is the open enrollment for the exchange. And we don't yet know, because I said this yesterday at the all legislative briefing, we don't yet know exactly what the impact on the insured rate will be because we're in the middle of open enrollment. But we will know. And I do think that I remember the days when we were at had a higher uninsured rate, and it does have a significant impact on our providers. Yeah, absolutely.
None
Yes.
of this money can go to help backfill any of those problems that they are creating for us with regard to Medicaid.
The way I see this is that this is an opportunity. This is its own opportunity that has its own sort of guardrails and allowances. But I agree with you. It doesn't directly impact some of the other policy changes that are on the table that are going to have an impact. Yes, that's true.
Rep. Wood and Rep. Kornheiser each have questions. So,
I have a bunch of questions, but I'm gonna try to sort of like hone in on, you talked about this not providing, payments for direct services, but you also talked in a couple of areas about, per member per month, and.
Oh, yes, that's a really good point.
So I'm trying to figure out how that comports and,
It doesn't, well, I'll explain why.
okay.
Yeah. Great question.
The other thing, the other things are, you mentioned a couple of things, child psychiatry is one of them, and I forget what the other one was, but, those are,
Yes.
those are direct services.
Yes, you're right, you're right.
And then enhancing blueprint transformation, I guess something that we've had as long as we've had the blueprint, I would hope that we are in a continual transformation process of updating and modernizing, things that we started, 2 decades ago. And I guess you're just taking advantage of having potential resources to do that. And then, of course, I have questions about SNAP, and I'm a little unclear about, it says the governor is directed to pursue extension of the waiver. And then you said, well, we haven't yet decided. And then that seems like it's been decided. And finally, we, you addressed this a little bit in terms of the EMR and EHR. We've obviously heard from some providers who feel like they haven't been involved in the conversations. I understand that, it's quick turnaround time. And I guess I'm interested, and you said it's not mandated, but I'm just interested in what the process will be if that's one of the things that is approved, how provider input will be achieved, and are there ways to do that that don't require everybody to be on the same platform?
Okay, wow, I think I got all of those. You may have to remind me.
Okay.
Yes, I was not entirely consistent. You're absolutely right. So the PMPM payments. So the idea there is if we go to the AHEAD model, that's the sustainability plan for those. So that's where those dollars have come from in the past, is through our federal arrangements through the all-payer model. We're going to be taking a break. We may be moving into the AHEAD model. That's a whole other area of policy. So that would be the concept there, is to transition. So you're absolutely right. And
We have a sustainability plan, but.
Well, yeah, it is a but. It is a but. Yes.
And the rules surrounding the funding were you can't use the funding to help pay for anything that it's an existing billable service. So things like the blueprint, like the PMPM payments, that's not a billable service, nationally with the with the code, a billable medical code. So that is the distinction there.
We created it.
There are some service level things that were included in the application, and that's because they all don't rely on traditional medical coding. And if they did, they would not be able to be included as part of the application.
I think you're just right about the Vermont CPAP program, the child psychiatry program, that it's ending. And I think we said, let's see if we can keep it going longer. So yeah, and that one may get denied for the reasons you say, I don't know, but I'm hopeful that they will view it as something that is really, because it's part of this e-consult concept, it's really a way to deliver services in rural communities. So we'll see. So
when talking about that, I guess publicly, when we're thinking about this, I just think we should be careful about our language.
Yes, you're right.
There's, that we're not providing any direct services.
Yes.
And in reality.
Trying some. Yeah, I'll be more careful. I appreciate that. Yes, it's hard to talk about this whole thing. I feel like I'm like eating an elephant every time. Yeah, so yeah, totally agree. On the SNAP waiver, we've been,
I make a suggestion to allow for the answer to the SNAP question. I think it's somewhat here as compared to right in the middle of the grant. And then go to Representative Kornheiser's question. If we have time, we can circle back.
Okay.
Some of the questions that Rep. Wood has asked. Is that okay with you?
So SNAP.
Just in terms of time.
Yeah. So pursuing the waiver, even getting the waiver doesn't mean we have to implement the waiver. So my understanding from the recent conversations I've had is that we have not made final decisions about whether or not we would put that waiver into place. So we were asked to pursue it, but we have not been directed to put it into place. So yes, I know it sounds a little semantic. I might have written it maybe a little softer than we wrote it in here. In order to reflect that, but yes.
More to come?
More to come.
Okay.
More to come.
All right. Yeah.
You asked the hard question about PMPM, and I'm glad you asked it because that's fun.
I have a very big picture question. How did you collaborate with New Hampshire as you were submitting your application, given what a big part of our healthcare system they.
How did we collaborate with New Hampshire?
We did collaborate. with
Okay.
New Hampshire. We did collaborate with New Hampshire. We spoke to them several times over the course of our application development. We talked initially, which was mostly just like sharing thoughts and feelings about putting together this application with limited resources in 6 weeks. And then we maybe talked 2 or 3 weeks later, and we had separately kind of had our skeletal model of what might go into our individual applications. I think the area between New Hampshire and Vermont where there was the most synergy was related to workforce. And we ultimately decided, I mean, it's really hard to coordinate application material with a different state in such a short time frame. But I think workforce, like we've heard from New Hampshire since submittal, I think some of our workforce initiatives will continue to pursue partnership on should they be approved and ultimately implemented. So we were in communication with New Hampshire. We've continued the conversation, and it will continue.
There's a lot that you said around medical records and sort of synergy of other services and non-hospital services that are deeply connected to hospital systems that I'm concerned with, like actually work in the Dartmouth context as well as other hospital systems context, given that there's large swath of the state that's really within that system.
Oh, well, certainly on the EHR, Dartmouth and UVM Medical Center, that both networks are on the same EHR. So if we had hospitals across the state on that platform, the same platform, it would be the same in both states. I just want to correct the record a little bit on the e-consults. Every single, we tried to write all of these to meet the obligations of the federal government in the NOFO to have the sustainability that it needs to have and to be compliant with how they view what is permissible under this application. So I will go back and read the full application to figure out exactly how we did that. But I just want to be clear, our goal was to meet the rules of the NOFO and to have a sustainability plan for everything, because that was part of the requirement. So
Good, because that gets right onto the bottom line of how the money's used.
Yep.
So if we can, and send us just locate where it is in the grant.
Sure.
Application, or let us know maybe a summary of what got, that'd be great.
Mhm.
I think we should move on. This has been really productive. And I think it's just the beginning of our conversations as we move into January. Well, this December 31st.
Yeah, yes, December 31st.
December 31st.
Thank you both. Really appreciate your time.
Thank you. Thanks for the opportunity.
We'll see, we'll hear more later on the transformation update. So we have the New England Collaborative Health Network and David Turner here. Welcome. Good morning. But David, I'm not sure everyone knows what the New England Collaborative Health Network is. And some folks do not know you, so it'd be good to have that introduction and come up and share for the record.
You want me to sit? Can I stand? Do I?
Well, please sit. Oh, yeah, please sit. Yeah.
So thank you for having me. I am David Turner. I'm the executive director for the New England Collaborative Health Network. We are not just Vermont hospitals, we're also New Hampshire hospitals, New York hospitals, and also FQHCs, home health agencies. Maybe at some point we'll get long-term care also involved, but our goal is to really work on the whole continuum of care and try to work more interdependently. So just my presentation will just be a brief introduction to who we are, where we've gotten to, and then we'll be open to questions.
When were you established?
So we were established officially on May 13th of 2023. It's in my slides.
Right ahead. And we aren't introducing ourselves, but we are around the table, and as we call on folks, you'll be able to meet each person.
All right. So hospitals for a long time have been looking for other alternatives to stay independent. And we put this grid together to kind of talk about the different pros and cons of being purely independent, which has some opportunities and some benefits around ownership and strategy. But then they give up the economies of scale, their purchasing power, the ability to work together with other organizations on a more formal basis. There's the option of being part of a much larger network, which might make sense for some, but you give up that autonomy, the local decision-making as far as what makes sense to your community, in exchange for, again, those economies of scale. There are other things you give up as well, and potentially higher prices for patients. The collaborative model allows you to remain independent. So we don't own the hospitals, we don't own the FQHCs. The ownership remains at the local level. We provide economies of scale. We could do shared administrative and services, shared technology. We provide a peer networks and subject matter expertise. There's a lot of the benefits you get from a larger network, you get with the collaborative without giving up that ownership. And so the third option seems to be the area that a number of hospitals and organizations are interested in pursuing. Next slide. So collaboratives, consortiums, coalitions, alliances are not new. When I was hired, the first thing I wanted to do is learn more about what are collaboratives. And so this is an example of some of the places I talked to. They've been around for decades doing similar work that we're talking about doing, from a not-for-profit status to a for-profit status, all of them using vendor partners. And what I mean by vendor partners, we'll go over in a little bit, but they're not doing it all themselves. Next slide. So our story begins with Ovation Healthcare and Chip Holmes, who was a great partner for a number of the hospitals in Vermont, and him working between them. All of them were talking about similar things, the similar challenges, and the need to really work more closely together. We talked about the third option, which is working more independently together. But one of the things that was missing was that the CEOs, CFOs have their day jobs, right? They had to focus on what was going on in front of them within their organizations. And so Ovation put the seed money together to employ me, to get this off the ground. It was a shared agreement between Northwestern and NMC, Copley, but they agreed together to see if this could work. And so I had 6 months. I had 6 months to see if I could put this together, take a vision and make it a reality. Little did I know that I really had 6 months. When they hired me, I was like, you were serious. But we talked about so many different things we could do, and where we ended up was we needed to take cost of it out of our shared service area. That would be more easily more attainable than focusing on quality and access and risk, which are much more difficult. And in the process, we'd be building trust. So can we work together? Can we buy together? Can we buy Band-Aids together? Let's see if we can do that first before we start talking about electronic health record, right? So that's where we started. Next slide. So here's our history. You asked when we were official. So this started back in 2022, meetings in Stowe, over and over again, lots of talk. It wasn't until September of 2023 that this became more formalized. I was hired. We officially became incorporated in an entity in May of 2024. So wrong date. Since then, you can see our timeline. So we're not old. We're relatively new. So we have a lot to build as far as relationships and trust. Next slide. Of course, we have guiding principles. We want to strengthen sustainability and resilience of the independent rural healthcare providers. We think we can do that through shared solutions, a collective voice, sharing best practices, building regional trust, and also shared service on a regional basis.
A quick question on the sharing best practices. One of my ongoing interests has always been quality metric data collection and analysis. So how is that data being collected, analyzed, or is it simply clinical case studies? How is all of that happening?
We haven't gone into quality yet. We've been focusing on some of the back office functions and getting
Got it.
together and talking together. And it's amazing, the willingness to share their challenges, to share, hey, we've tried this, we've been successful with that. And so we are starting to get into quality. We in a slide coming up, we just started a Chief Nursing Officer Council. So we may get into that very soon. The care coordinators amongst the network also want to get into learning and working together. So, where we started with back office, it seems that we're already to the quality direction.
Thank you.
Slide. So who are we right now? We have 7 hospitals and 4 community partners listed there: Brattleboro, Copley, Northwestern Medical Center, Adirondack Health in New York, Cottage Hospital in New Hampshire, Grace Cottage, and Gifford Healthcare. And then you can see the home health and these who are part of us right now. Next slide. So we've also achieved growth. So back in May of 2024, we had 1,800 staff who were under our sort of network. We've been able to grow that to 4,500. Covered lives, we started at 129,000 in total. That included also New York and New Hampshire. We're at 313,000 now, but if you carve that out to just Vermont only, we're actually around a third of all Vermont residents being somewhat affiliated through the members and part of this network. And of course, square miles, we cover more square miles. Next slide. So about us, we are a for-profit limited liability corporation. We chose this because we wanted the ability to share profits or income or excess dues. We didn't want to keep it in the collaborative. We wanted to give it back to the hospitals. And these decisions are made by the hospital members who own the collaborative. Each one has an equal share and an equal vote. They're independent board of directors, with each hospital CEO sitting on the board. Our community partners are able to opt in and opt out of all of our initiatives and programs. There's actually no cost for them to be part of us as long as they participate in either our GPO or our employee benefit plans. So for them, it's a low risk financial risk for them. It's all upside. For the hospitals, we're able to offset the annual dues with what we call admin fee share revenue. And that's so because we're for profit, then we can give those dollars back to the hospitals to offset those dues. That's the reason why we went with the for-profit status. Next slide. Trust and commitment is foundational in any collaborative alliance. And it starts with the founding hospital CEOs having a shared value and vision, but also moving down into our member hospital boards where we have shared events. We include them in our networking and have board events where the actual member boards get together to share information and learn from each other. Of course, the collaborative board, the way we create trust and commitment is 1 seat, 1 vote, regardless of your size. And then the affinity groups, which I was alluding to with the CNO, allows us to build that reliance and build deeper alignment in the culture. Our community partners, they share resources and expertise. And our community partners are again, sitting at the table with us in all of these councils. So that's how we build that foundation of trust and commitment. So if a hospital CEO were to leave for whatever reason, we've built that culture so that it just doesn't end. Next slide. So who are our trusted vendor partners? I mentioned Ovation Healthcare. We also have the Richards Group and Hub for business insurance. They are our subject matter expertise. They are innovative. They understand collaboratives, have worked with collaboratives or alliances before. So it's not like they bring that expertise to the table, and they're highly trusted because we've worked with them in the past. So it's not like someone new. Next slide. So these are the councils I was referring to. So right now, each hospital has a representative and community partner has a representative on these councils: information technology, human resources, supply chain, finance, clinical nurse education, chief nursing officer, which just started, and we will be starting a care coordinator council. Purpose of these groups is to build a network. When I was working in the hospitals in Vermont, I was working at Copley in finance going, who's my resource? Who do I reach out to if I have a question? And the answer was, well, look in your Rolodex. My Rolodex was not very full, so I didn't have a lot of people to go to. This is a way of creating those peer relationships in that network automatically. They also identify new opportunities, and when we have a plan, they help execute it so it's applied consistently and it's applied effectively. Next slide. So these are the 4 pillars. Again, we looked at, we wanted to see if we could keep appropriate care local. We wanted to see about reducing costs. Workforce was also on our list. We had in the other category, payer contracting, revenue cycle, looking at external grant funding. But because our scale was low to begin with, and because we felt the other pillars were difficult, we said, let's focus on cost. Let's take care of the continuum. So that's the pillar we focused on. Next slide. So in year 1, these are the areas that we've focused on. We got everyone on the same group purchasing organization. We've moved people to the same group purchasing for employee benefits in those areas. Workers' comp. We also found savings. So a number of our members were part of the New England Alliance for Health, which is the Dartmouth collaborative. Let's put it that way. They found at the New England Collaborative more equality, seat at the table, lower dues, and when we put our GPO up against their GPO, there was significant savings. So we found savings there, obviously. Next slide. Right now, in year 2, which started in May of 2025, we continue to focus on supply chain with additional standardization, additional tier discounts. So as we collectively buy together, we're able to also create our own additional discounts within the GPO. So we're seeing that now. In fact, last month, there was $47,000 identified in savings for tier savings because we pooled our buy together. Memorial Home Health and Hospice in year 1 has saved $50,000 in their medical supply costs. So it's not small. In 2026, we will have a group plan for life and disability. In 27, we'll have vision and dental. Business insurance, we're working on right now, where we're seeing significant savings or cost avoidance. Yes.
Is this because you're combining a risk pool of all the folks in the collaborative, or how not?
A shared risk pool per se,
Okay.
like you're probably thinking. But when the carriers look at us, they'll look at us
Negotiation.
collectively, right? And so the broker says, hey, look, have some losses here, but look at all these positive losses here. So we're not sharing risk, but they're looking at us collectively. So we may get into shared risk, but we need to build that scale some more. We are looking at agency and locum contracts, also looking at telehealth contracts, maybe hospital-based contracts. We tried fuel oil and propane, which was a big thing for some of our CEOs. We at the beginning said, let's just buy fuel oil together. That should be easy. that was probably more difficult than GPO conversion and employee benefits. There's so many complicating factors. And, in the end, I think supporting the local regional vendors is probably the better way to go. So next slide. So this is our projected cost savings or cost avoidance to date. You can see in the categories where we have achieved those savings and how much. So to date, we've saved about $7.3 million. I think that's a little understated. I think there's more there. The hospitals have the lion's share of 6.35 million as far as that overall. But our community partners, which we only have 4 of, have all saved combined almost $1 million. The average hospital right now is saving just over 900,000. And actually, our community partners are saving about, on average, 250,000. So we've been pretty successful, I think, so far in taking cost out of the continuum of care. There's a lot more opportunity in that by doing shared services together. Next slide. We're not only just looking at saving costs, we are looking at developing shared leadership development programs, which will help retain staff, which will help with effectiveness. We are talking about some shared IT specialists, some nursing specialists that some other small hospitals don't have, that the large hospitals might be willing to share, especially cyber expertise in the IT world. We plan to get a risk management work group together. So hopefully somewhere down the road, we could share risk. But first we need to understand where that risk is and how we can minimize it. We also have those other areas we're working on. Interestingly, human resources, that council, it's amazing how much is still done by hand, by manual. And so we've been talking about how do we modernize? How do we find efficiency in just human resources? I was surprised with how much is still manual, but anyway.
I'm gonna call a friend or two on the rural health transformation grant. Is there any money in there for human resources modernization updates? Yes,
These are human resources systems.
yeah, thank you.
Good. That would enable us to then share staff as well if we're on the same system. Next slide. So what's our role? What could our role be? We want to focus on enhancing the functionality within our organizations for our members. That could be any one of those things that have been talked about over and over again, from sharing revenue cycle to shared network to sharing providers, sharing care coordination. I put a plug in there. One of the things that would help us, I'm not trying to sell it, but I put it on there, would be a shared IT network and a shared electronic health record and shared HR system. What would that do? Jill talked about interoperability just a few minutes ago. And I think that is certainly one of the opportunities with closing referrals as far as, being able to better monitor patient compliance. We'd be able to share providers who then are only working in one system. They can only be trained in one system. But there's also some opportunities in cost savings, taking your IT group and saying, hey, we could be more efficient. There's some that are just generalists who probably could be shared and be utilized better. There's the opportunity to share revenue cycle. If we're on the same EHR, then we can share revenue cycle from a consolidated network. Care coordination, risk management, utilization review, analytics. We could probably still achieve it, but it would be much easier if we were all on the same IT network and EHR. But overall, what the collaborative wants to be to Green Mountain Care Board, to AHS, to you, is a vehicle, a tool towards hospital transformation. We're still trying to figure this out altogether. And the collaborative has a role where it makes sense, but it can't be the owner of everything. There's some things that have to be regionalized and owned by that hospital region. Now, we do talk about also macro collaborative, and we also talked about micro collaborative, which we're getting close to, which would be, hey, let's take it from the big picture statewide. look at things and really focus on what's happening locally. A great example would be in Lamoille region, where we have Lamoille Home Health, we have Lamoille Health Partners, we have Northern Counties Healthcare and Copley Hospital, all under the same, all under the collaborative. What could we do together if we're now more formally put together? We've already seen where Copley Hospital has shared supplies with Lamoille Home Health and Hospice because they didn't have it when the patient was being discharged. Well, that allowed the patient to be discharged because now they had the more formal relationship of being able to share supplies. Is a great example that I heard just recently. So, last slide. Oh. If you want to get in touch with either myself or my board chair, Joseph Wooden, who is president and CEO of Copley Health Systems, that's our information. So I want to make sure you had that for any further questions.
Thank you. This is terrific. And I will say that Representative Black and I had an opportunity to meet with the group, the whole, like, is it an annual meeting? I don't know whether it's an annual meeting or
It was Copley's board retreat, and we
Yeah.
pulled that together.
coupled it with
Yeah.
your organization. I found that really refreshing to have so many folks in the room with different ideas and perspectives coming together. So it sounds like that's happening. I do have a couple of questions. I know others will have questions. I'll go to the micro first. So as you're looking at the micro, are you looking at reaching out to independent practices in addition to the other organizations that are within the region?
Yes, so we continue to reach out to independents, hospitals, other FQHCs,
Primary
practice. It's for some of the smaller ones, there's not the huge benefit at this point for cost savings because they're so small, and one of the biggest expenses they have is employee benefits, and there's not enough spend there to make it work. We'd love to create a shared risk pool with all of the small ones. We're not there yet, but that's something that myself and the Richards Group have been discussing, so.
And then you talked about not all the capital that is saved theoretically goes back to the hospitals. But then you're also sharing resources with community organizations. At what point would you consider sharing capital with community resources? Or is that anything worthy of discussion? I mean, obviously, everyone's in trouble. I mean, just what is the thinking of that?
Yeah. Capital, you mean like buying capital equipment or?
Money, capital equipment, that, yeah.
That would be an individual hospital's decision, not.
Okay, so there's still that independence.
Yes.
It's
right.
not a collaboration isn't gonna say you have to do this or that.
That's correct.
All right.
We've already seen the growth line in on cost of supplies go down at our FQHC and our home health agency. So
It's
it's
savings happen.
it's happening.
Yeah, okay. And then my other question is, well, as you're talking and you're creating this culture of sharing and reducing fear, one of the things we like to see is developing permanency. And what are the strings that are tying all of this together? I mean, we can't be dependent on one person. I know how very enthusiastic Joe Wooden is and has worked hard on this, and then you are. And so how do we establish the permanent relationships that are being developed right now?
Yeah, well, I'd like to say we've already established some of those at not only at a collaborative board level, but also the member board level, also within the leadership teams, where they're already relying on each other. They're already sharing best practices. Eventually, could we share some HR people together? So, I think there are risks, of course, with anything. We could right now, one of the risks would be expanding too quickly, getting our scope too large before the trusted relationships are foundational and stronger. So, so we need to be careful of that and also change, and the pace of change. So, I think that, we want to change, but we need to change in a way that we're all kind of rowing together and are ready to row together. But, right now, let's buy Band-Aids together.
Thank you. And just one comment, it's really important, I think, as we've been talking about financial sustainability across the board, solvency, sustainability. And I understand that it's important for hospitals and community folks, independent providers, FQHCs, everyone to understand the reality of the situation. And it sounds like the group that you're working with gets it and is working closely with AHS. We'll hear about the transformation going ahead.
Yeah, I think, just in listening to Jill and the question about, there's going to be reduction in Medicaid payments. How do the hospitals survive? How would they maintain their services? We have to look at cost.
Yeah.
So, and we provide that structure, I think, without having to be owned. So.
One more question.
I do. As you're going through your presentation, I'm noticing the logos for Ovation Healthcare. And I'm hoping you can go into a little bit more detail, what the relationship is, financial, with Ovation Healthcare, because when I think of Ovation Healthcare, I think of Springfield Hospital.
In a positive way.
What is the relationship? What is the relationship?
It is a relationship.
What is the relationship between Ovation Healthcare, which I believe is a private equity backed
They are.
consulting,
They are.
a for-profit?
They are.
What is the relationship between the New England Collaborative and Ovation?
Yeah, for us, so they were foundational. They were there in the beginning to say, hey, let's get this off the ground. Let's put our money, let's put some seed money in. They have a seat at the board, just to be clear. They have a single vote, but they oftentimes just vote with the rest of the group because it's an independent group. And so most of the CEOs, have their power is very limited, if that's what you're concerned about. As far as
I think what I'm wondering is where they're making their money.
where they're making their money,
Yes.
well, just like any other organization like Ovation, they make their money on potentially group purchasing alignment. They make money on advisory services, on outsourcing services. So it's not any different than some of the other organizations who are involved with the hospitals today.
That might be another issue to take up during committee time. Thank you. This has been really helpful. Are there any other? Okay. Thank you for your work.
Yeah, welcome.
All right, so we have,
We're 5 minutes.
5 minutes, we were 4 minutes behind earlier, and then we're 5 minutes behind, so Emily Brown. Oh, my God, it's the transformation. I'm sorry. Roy and Craig Jones isn't here, but is it Aaron or no, Caitlin?
Caitlin, yes.
Caitlin is here, okay.
Katie Carroll, I typically go by.
Thank you.
Yes. Thank you all for having me.
We will ultimately catch you.
So I can start. For the record, I'm Katie Carroll. I'm the Care Transformation Director at the Agency of Human Services.
I'm John Steroy, an Executive Director for Blueprint for Health, also at AHS.
Thanks so much.
And
for
it's
having me.
snowing outside that window. Beautiful.
Great. So do I just jump right in? Okay. Great. So today we're going to cover with you some background on transformation priorities and just ground everyone in where we are in care transformation. We're going to give an update on the hospital transformation grants and the hospital transformation planning that we're doing with hospitals. And then we'll move into some regional and statewide transformation planning updates. So this is a visual that we like to use to just ground in where we are in the care transformation work that we're doing. So we've been doing regional convenings. We have the hospital transformation grants, and we're working on getting an analytics vendor in place. And all of that is feeding into this blue box in the middle, which I would say we're right in the middle of this synthesis of all of this work that's been happening. We're really in the process of combining stakeholder insights and really understanding what the priorities are going to be moving forward, and really moving into some concrete planning with hospitals, and identifying where we're going to be doing larger statewide and regional projects. So we wanted to give an update on the hospital transformation grants from Act 68 of 2025. So we had a portion of money that we were able to grant to hospitals to support transformation planning. 10 hospitals have received notice of award for those grants, and 3 we're still working with to get their applications to meet the goals of transformation. We have 5 that are funded to do to use the resources for hospital and regional planning. So that was one of the main ways we were hoping the hospitals would use the money. Many of them are continuing to use existing consultants like Hoffman Hall to really better understand where their opportunities are in transformation and what they should be going deeper into for their transformation planning. The other 5 we bucketed into capacity and acuity management. So a lot of those are doing, using them for resources to really be able to participate in some of the acuity and transfer management work that John will be talking about later, or to really understand their capacity to take on more acute patients, or understand what kind of tools or resources they would need to do more of that work to support those statewide goals. We are still in the process of moving them through the full grant agreements. But we have started doing transformation planning, which is one of the main activities of those grants, grant agreements. So to support hospitals in transformation planning, we created a structured document, a template for them to be able to populate what their goals are. We have some really specific sort of questions that we're asking. A lot of them are around how these goals can be measured and monitored over time, so we can make sure that things are moving forward as expected as we're working through the plans with the hospitals. We have 4 sections within the plans, and we did share that document with you all to be able to review. Basic hospital information, the bulk of it is that plan transformation, so how they're thinking about their goals and what they're going to prioritize. There's a risk mitigation section so that we can make sure that they're thinking about those pieces, and then also a communication strategy where that's relevant for any of the big changes that they're making within transformation. We are working closely with hospitals around these transformation plans to make sure that what they're including contributes to the Act 68 transformation goals, as we would expect. As I mentioned, we really want to make sure that they're measurable and really able to be tracked over time, and that they tie out to statewide and regional considerations, so that everyone's, on the same page, which I think is our main task within this work. Some of the support that we're providing to hospitals is we're really trying to make this process easier for everyone and make sure everyone is really aligned. So making sure that we're really clear about what we want in transformation plans, that we're able to answer questions, move things forward. We're offering individual hospital meetings. Office hours with our staff are being offered weekly, so we're starting to schedule those now. Excuse me. We are trying to be really clear about regional, the difference between regional and hospital goals, and really making sure that regional goals are tying out to some of the bigger themes that we want people to be focused on. Analytics support, we've mentioned a lot, is one of the ways that we're planning to support hospitals. I didn't mention this on the previous slide, but draft plans are due in January. So that's when we're really planning to pick up on some of the analytics once we have really concrete ideas from hospitals around what they're planning to work on, so that we can make sure we can prioritize those that will be most meaningful, and really bring some strong analytics into how they're thinking about moving forward with their plans as we move into the final plans that are due in March. And we're also offering technical assistance and additional supports as needed. Some hospitals obviously need more than others. So we're taking requests for additional supports as they come up.
Do you travel to each hospital to help with that?
We do. We're traveling a lot, yeah.
The driving and the work involved in making those contacts.
Yeah, yeah. John for sure has been around the state more than I have. I've only been in this role for a few months, but we do have some more travel planned to be in person at hospitals to really support that work.
Absolutely. So speaking of travel, it's a pleasure. It's great work. I showed this map last time in terms of divvying up different parts of the state, and I'm gonna say, as I said, was that October? Was that November?
October 9th.
Oh, thank you. Dates. As I said, on October 9th, there has been cross-pollination or crisscrossing of some of these groups of hospitals as they work on collective goals. Some goals have included different hospitals coming over to different groups. For example, Northwestern Medical Center joined a meeting about acuity and capacity management in St. Johnsbury with North Country Hospital and Northeastern Vermont Regional Hospital. Rutland Regional Medical Center joined a discussion in Central Vermont that was hosted by Gifford, and Central Vermont and Copley Hospital were at. And actually in regards to capacity management and the topic of interfacility transportation, I have with my team, I think, gotten all of Route 4, south of Route 4 to meet. That'll be a Teams meeting, but before December 25th. So that'll include Rutland, Southwestern, Brattleboro, Springfield, Grace Cottage, Mount Scottney Hospital. Lots of work from our local Blueprint program managers, quality improvement facilitators, people here in the room, online listening. So we are absolutely traveling to hospitals, moving some of those discussions to Teams, but also still moving to hospitals today. For example, in the room yesterday, Aaron Just and Dr. Craig Jones, who unfortunately wasn't able to be here, were just at North Country for most of the morning in Newport. So yes, we're absolutely in rooms with people in person having these detailed discussions, Senator Lyons, absolutely.
So let me ask a quick question while Jill is here behind you, and thinking about the word regionalization.
Okay.
We've started to hear about and see. We've been thinking regions in the state, obviously. So, and there's 5 regions here on the page that are also referenced in the transformation grant, in the rural health transformation grant. So these are the things that are firmed up now for us as a state. These are the regions that we're settling on, working together.
Yes. I really want to emphasize they're topic specific, and I liked David's term, the macro collaboration and the micro collaboration. It really depends on the topic. So we tend to adjust what those regional lines are based on the topic.
Regionalization is just the way we go about the work, regardless of where it is.
I hear your point. I hear your point.
Care or primary care or hospital-based primary care or others. It's all depends on the type of service that we're talking about.
There's a lot of microenvironment variability, and I saw that as a hospice medical director in Vermont and New Hampshire as well. There's a lot of microclimates and variability depending on the specific area. And the map's the map's great, but it's static and it's 2-dimensional. So there's not topography in the map. I don't have a cartoon showing all the different ways we're grouping.
Sounds like a video game to me. It could be really disaster.
I don't know anything about video games. Never allowed to have an Atari.
One more quick question. I think this is helpful for understanding how things are happening.
There's different regions, but several of those hospitals are part of the UVM network and operate within that frame. So how do you?
Yeah. And same,
I was just thinking that.
same with Southwestern Medical Center and how do we operate in that frame? they've been great. Everybody's just CEOs and their leaderships have absolutely listened to regional concerns, local concerns, their own network or systems. It's been quite fluid. So I've been, and there is, yes, of course, there is focus. You're getting into more focus. I think we're really trying to do both all simultaneously. So address network concerns as well as regional. It's really, I mean, it's happening on both
Yeah.
levels.
I was just going to add, I think the way we've been kind of defining how we think about like a regional goal within the transformation plans. And I think that speaks to some of what we're talking about of like, what does it mean to be regional? And we did define that as really anything where two organizations are working together on the same goal. And it could be a hospital and a primary care organization. It could be two hospitals. It could be, a network and within that network. So we have been trying to define that more clearly within the transformation planning, just to make sure that we're really thinking about regionalization is really anytime we're cooperating among these organizations to be more efficient in the way we're providing care.
Thank you. I mean, this is really helpful, but it'll also influence the statewide plan ultimately. So
But locally, the hospital owns
yeah,
most of the practices.
Yeah.
It's very difficult to find an independent. There is an independent.
We're
There's
working on
there's
that,
something that's
Senator.
facilitated with Copley. But to find anybody that's independent is challenging.
Well, and we have to work on their viability. Yes.
Okay. Oh, okay. Well, yeah, sure.
Senator Perchlik.
You had mentioned the statewide plan, and I'm not on a committee of jurisdiction. I just wondered how this plays into the statewide plan. And I don't know a way I can word this, but is there any way, and people on the committee that wrote the legislation can kick me under the table, but is there any way that plan could be done sooner? Because the thing I'm hearing from other folks is that we don't have till 2028 to figure this out. And so I assume this is all folding into that and you need the 2 years to fold it all in, but how are we going to get some information before 2028 on what we need to do?
So, I'm looking at Joe.
Oh, yeah. Oh, sorry, go ahead.
That's okay. I'll come in.
Okay, here, John.
I just want to address the timing. Jill Olson, Medicaid Health Systems Director for HS. So I would say that I think this work, this regional work is where the work is of the actual change. So I do think it's important for us to have this overall plan and to fit all of the pieces of all the work that we're doing and to identify the gaps. We really need to do that. But to me, healthcare happens for the most part, within communities and regions. That's where it's happening on the ground. And that's why I think this is the most impactful part of that work. So I'm less worried that we have the full plan in place in 2028. And I'm more concerned that we do this work to figure out what kind of services we're going to have where. I think that's the crux of what the work we need to do now. And I'm so grateful that we have this team in place to do that.
Yeah, I was just going to add that these plans that we're doing now and the work that we're doing now, we do see that as being a big portion of what that strategic plan is going to look like. So I think it's not going to be, in 2028, there's a brand new information about what needs to happen. I think it is all feeding into that, what that work is.
You need 2 more years.
Yeah.
Structurally, the way the committees were set up in statute works very well. I was with Dr. Homan, who chairs the steering committee yesterday at her practice in Wells River for 30, 40 minutes. And I was talking to her not only about the steering committee work, but about the regionalization work. She then, with Dr. Garfield from the Vermont Children's Child Improvement Program, they go from the steering committee to the healthcare delivery advisory group that Jill Olson convenes. So there's very it's just structured quite well to facilitate things happening quickly. And a lot of these goals are going to be worked on within months, weeks. I don't measure the work. I measure the overall work over years. I measure the immediate work in weeks to months. What are we doing right now? if that's helpful. It's very process improvement oriented. It's very much doing both things at the same time.
Rep Black has a question.
Please.
I think just around, and I think the regionalization, of course, is a great goal. We should be moving towards that. I'm wondering now that we have siloed regions, if there is still ongoing conversation statewide. Mainly I'm thinking about how does UVM Medical Center as the one and only academic medical center fit in with other regions? And is everybody at the table?
Absolutely. And I think some of my examples in my slides will make that more concrete to show you and talk to you and describe it in detail. I'm just gonna go through the slide and then give some examples, and Representative Black, I can speak to that specific health system as well, in addition to the examples I prepared. So the geographic regions are determining priorities and goals very much in the structure and with the support that Katie spoke to. And those do include things like clinical specialties, staffing, coverage. So after hours, weekends, what services, where, how. Wonderful to have David speak in terms of shared purchasing agreements. So they're not the only way to go about that. He mentioned the group in New Hampshire too, but so that I'm not an expert in all the shared purchasing, but that's part of this work as well. Really happy to have Drew here in the room. He represents with a couple other EMS providers. Maybe they've come and gone, but our collaboration with the Department of Health and Will Moran, the chief there for EMS, and just the robustness of discussion that have occurred around not only transportation and interfacility movement of patients, which is hugely, hugely important, but how are different hospitals of different sizes and different capabilities managing acuity? Is it optimized? And I can give some examples about how that's going. So patient acuity management, communication, capacity management, the logistics of moving people around. I'm going to just highlight some efforts in the Southeast. So the Southeast is those 4 hospitals that I mentioned in the slide before. Hospital leadership have agreed to bring data together to look together at specialty services needs, specialty services related gaps based on primary care referral data, based on wait times, based on inpatient transfers. There's a new term that I'm still learning, out and back procedures. So this is patient doesn't necessarily get admitted to the hospital, but they need a fancy sort of very quick procedure that can be done somewhere, but they come back to have the next 20 or 40, 36 hours closer to home at the institution that they're at. So really looking, those CEOs and their teams looking in detail at that topic. We've held meetings in the north, in central Vermont. There's the Mount meeting I mentioned already in the south on December 16th, looking at opportunities for further investment and coordination and support for EMS. It's just been a fantastic aspect of our healthcare spectrum that I'm getting to know and learning about to see how we can support all of their efforts, both legislatively mandated and from the ground up. Just incredible examples, I think, out of Drew's organization and others for arrangements that I'm really trying to highlight other parts of the state to utilize too. I'm gonna get to some survey results in the next slide deck, but I do want to get to your question, Representative Black. And my perception of both the University of Vermont Health Network Medical Center, Porter Central Vermont Medical Center, and the UVM Medical Group is that we have been involved with each of those entities. The medical group most recently around specialty conversations from emergency medicine to hospitalists to oncology to cardiology to neurology. They were very involved and very present in discussions yesterday for the Northeast Kingdom. I've also connected them with some of the chief medical officer in the Southeast to really look at, like, we're Vermont, we're all Vermont. Like we need to focus and be available. By what means, I don't have answers yet. By what arrangements, I don't know, but we're definitely pushing those discussions. They've also been very instrumental in the teaching us, but also learning how we can utilize the capacity that both Dartmouth Health and they have for coordinating transfers. And one of the examples that I'll touch on a bit when I get to a couple slides is again, new term for me. So I'm going to share it with you all, getting to a least call system. So instead of a nurse practitioner at a hospital getting a no for a transfer of a patient and then having to call 1, 2, 3, 4, 5, actually getting to a least call system where would it be possible? What resources would be needed for one of those larger systems that already has their own in-network capabilities to then also be of assistance and of service to out-of-network hospital patients who need to be transferred to a higher level of care that doesn't necessarily go inside their network? Those are the types of questions we're asking to really push for greater access, greater responsiveness, less administrative burden. I think I can go to some of the survey results. So, and I'll go through a few of the questions we pulled out. Centerlines, am I okay on time? We started 4 minutes behind and I'm okay to go through these?
Well, you've got 2 more minutes for real time, but we're
Okay.
gonna extend it a little bit more.
Okay. So hospital regional survey results. Some of the points I'm going to focus on here were, and I'll share the questions with you as well, but moving to a common electronic health record platform, participating in statewide managing of acuity capacity and transfer, engaging in clinical service redesign, and then implementing a social needs closed loop referral platform. So I'm going to try to get to the end, Senator Lyons, because I don't want to miss out on that social needs closed loop referral platform. Oops, no, not the right way to move this. Okay. So on the question of common electronic health record, this is a question that was put to the 14 CEOs. You can see there's an asterisk there because one CEO chose to answer in 2 places the level of interest and already use a common EHR platform. So the full question on this item, assuming that, so this is what they read, this is the STEM, this is the question. Assuming that startup, transition, and maintenance costs are favorable for your hospital and your hospital has a meaningful role in EHR oversight and governance, indicate your level of interest in using a statewide EHR platform. So for me, seeing this, that nobody's disinterested was helpful. This is helpful information to talk about it and to get there. And from what I understand, this discussion happened before I landed in Vermont in March 2013. It happened before the Oliver Wyman report featured it as a topic, and the discussions continue. So I'm not thinking of anything new here, but I wanted to have a survey result to be able to share with you all of where are we as of, I don't know, this was just the end of November, right before Thanksgiving, I think they filled this out. So this is information. Next slide. In terms of managing acuity capacity transfers, regional meetings with hospital leaders have highlighted the need for a coordinated statewide approach to managing transfer and transportation services. And what we said was, please choose your organization's preference. And 12 out of the 14 leaned, again, 1 point in time, 1 question. I know it's a bit simple, the details aren't there, but expanding existing capabilities and coordination at either the health network and or DH. So what are we doing next? We're going back to them with these results and looking at feasibility. What would it take to expand beyond just your network so you could serve? On the clinical service, I know I'm short on time, so I'm just going to get to that last slide. Clinical service redesign. So this was really helpful to me too, so 2/3 of the hospitals have an existing approach, a little more than 2/3, for sharing providers and staffing with other hospitals. So if you want to have an existing structure and you don't have one, where would you like to go? What type of technical assistance might you need? It falls to management services agreements, joint ventures. This is helpful information to guide us. And then where really my mind went first was, what are those services in the consultation model specifically for telehealth that you would prioritize? And that's the list we got. So again, trying to really bring clarity to how to prioritize and where to start. So again, this is one-on-one discussions. This is regional discussions. This is looking to specialty providers too. The social needs closed loop referral. Question, would you be interested in having access to shared secure social needs platform that also includes closed loop referrals? So you don't just give them the information, you can actually track, spoke to family, initial meeting occurred, services delivered, so that it's not just a warm handoff, I call it a warm handhold, that's me. But you actually see them through to the end, and you can track it for your record and for quality. So that was that question. We are still going to be utilizing some different funds for primary care technical assistance. And that was something I'll be able to tell you more maybe when I come. But I know you probably have some questions, and I don't want to take away from I think I don't want to take away too much time from them. So.
Now, this is great. And I know we'll be coming back to this in different ways in our committees. Reverend Kornheiser.
Adding Senator Perchlik's caveat about like, don't want to mess with the train that you have running here. It seems.
Train, is that what you said?
Yeah.
Oh, nice. I like
And it seems like maybe the federal government is. And so I'm curious how you see the changes in provider tax, the loss of Medicaid eligibility, the increasing uninsured rate, fitting into the.
Sure. Thank you. I'm really fortunate that when I became the executive director for Blueprint for Health, community health teams, which are part of the spectrum of services people need, not all, but to have a nurse care coordinator, a social work care coordinator, a diabetes educator, a community health worker, even short-term or maybe medium-term counseling, those services through community health teams are not billed. They're provided at no charge to Vermonters. And so I feel very fortunate to not only try to advance that program, which we want to do, we want to modernize it, but also to protect it and make sure that those value-based prospective services for community health teams grow and become more available and strengthen. So that's really, as the Blueprint executive director, that's pretty much the only solace I can take in, because there's not a lot of other solace to take. But I know at least that my program and the field staff and I just looked at the numbers yesterday.
I'm not looking for solace. I don't think there's a lot of
okay.
I'm wondering like, how are you pivoting?
How am I pivoting?
Or how is?
On what the federal government's doing?
How are plans for the transformation pivoting?
How are plans for transformation? Do you want to help me with that question? Because I'm not getting it.
Yeah, I would say we can try to take it back and answer it more thoroughly, but I think my first thought is that we really are just trying to support hospitals as they're coming up against these challenges from these changes in the federal government. Like we talked about, we don't know exactly what the impacts from Medicaid are going to be yet. We don't know what all those impacts are going to be. We're just trying to, as we're building out these plans, make sure we're taking into consideration all those stressors that continue to just come up.
I guess I'd offer that I think there are ways we can mitigate some of those harms and plans rather than just waiting for them. And I hope that that's part of your planning for transformation.
Yeah, we can definitely provide some more information on that.
Good question. Thank you.
Yeah.
Any other questions?
Can I just expand on that a little bit? Because I ask this question every year. Are you worried about Blueprint funding? I mean, you're going to lose eligibility this year through the commercial market, the individual, possibly the small market, the premiums have increased, Medicaid turnover we're facing. Those are all fewer insurances paying into the Blueprint.
Yeah, we're definitely looking at our payment model and whether the model Representative Black that we came up with for the mental health integration, which is not technically a per member per month, we're actually already begun discussions of whether our model that's worked for 20 years actually needs to be changed to a model that actually sets a floor for minimum number of people funded to keep the funding at least level. So yes, we are concerned about the changes that would come with that model and are looking to modernize that model to keep up with these changes that to some extent are out of our control, but we have the ability to look at our models for calculating funding so that we can continue to draw down meaningful dollars. Yes, it's definitely an area, but we've talking about
providing services for people who are not paying into the system.
Oh, the free riders. So okay, I hear you. Yes, that's the Act 51 report we published a couple years ago. Yes, and trying to mitigate those concerns. Yes, I think about that a lot too. Absolutely.
It sounds like we'll be working together a lot.
Good.
as primary care is going to be a priority in the Senate, and so we'll be hearing from you.
Thank you.
And any other burning questions? I just want to say thank you. Thank you for your work. Thanks for driving around the state and bringing people together. It's just amazing, really. I know, and that's for everyone who's testified. I know there are a lot of specific questions that we have and we want to keep moving forward. But the work that you're doing represents the horses out of the barn. Let's keep it going in the right direction. Yeah. Thank you.
Thank you so much.
Emily Brand.
Do we want the horse out of the barn? Do we want-
We want these horses.
So they're out of the barn.
It's gonna come back.
I don't know if we're trying to get them back.
If you let it
Buy
go,
them for
it
future.
comes back, you know. It was.
Great. Good afternoon.
Well,
Thank you. My name is Emily Brown. I'm the Executive Director at the Green Mountain Care Board. It's nice to be here with you all. So I have been asked to come and speak about recent outcomes from 2025 legislation. So these were legislative changes that were made last year and had a direct impact on a lot of the outcomes that you saw come from the Green Mountain Care Board this year. So just to highlight quickly, I know many of you saw these slides yesterday, but Vermont does remain an outlier on healthcare affordability. This slide Chair Foster pointed to yesterday. We have the highest healthcare costs in our country. We are not only an outlier nationally, but also regionally. And of that healthcare spending, hospitals make up a major part of that. Increasing to almost 40 or 50% from 2018 to 2022. And this is really just to talk about what impact, like I said at the beginning, legislation had on the growth of our healthcare spending last year. So as many of you already know, Act 55 was passed last year, which capped outpatient drugs to 120%. That had a huge impact on our healthcare spend in the state of $140 million. There were also other additional reductions to hospital budgets, which occurred last year due to the Green Mountain Care Board orders, in a total resulting amount of $230 million. So this is really a great example of what I think we can do when we all come together and really work on solutions. I think Chair Foster did mention yesterday, while this was a great outcome, it's not necessarily something that we're going to be able to replicate year over year. We do need meaningful transformation to stabilize and reduce costs to our healthcare system.
Just a clarifying question. So when he said yesterday and you're saying today, do you mean that you won't be able to add another 230 million reduction next year? Or do you mean that that reduction isn't part of the baseline?
So I think I want to say it's both. Well, maybe it's the former. So I think the Act 55 reductions were a one-time reduction. So that is now built into the hospital budgets. Other reductions that you're seeing here, the 94 million and 31 million, those were savings that the Green Mountain Care Board found within hospital budgets that were reduced last year. That will be built into the baseline, but then those are obviously going to increase.
Yeah.
So I think it is a baseline, but there's just not a lot of other areas that you can point to that you can get another 4 million of reduction that is going to happen year over year.
That makes a lot of sense.
Okay. Thanks for that question. And so with those hospital budget reductions came reductions to health insurance premiums. So this slide shows reductions to our QHP plan premiums. So you'll see the total revenue reduction between MVP and Blue Cross last year was 49 million. This is a result of the Act 55 cap that I mentioned, the other savings that the Green Mountain Care Board, the staff mostly identified in the filings. And I just want to say too, that this was a great result because as many of you know, there are a lot of challenges right now, as was, talked to in the last presentation happening at the federal level. We have a lot of changes happening with Medicaid. We have the elimination of the subsidies for the ACA market. So the fact that we were able to really reduce these costs and get these premiums down to where they are or where they were approved is a success. I also just wanted this slide reflects the small group plan reductions as well. And so that was about 23 million.
If we didn't have the federal government, we'd be in good condition, more or less. Sorry.
So this slide is just again a summary of, I mentioned Act 55. This points to other acts that were passed last year that again went to trying to update and reform the way we regulate healthcare. So the legislature under Act 68 implemented the reference-based pricing framework. That is something the Green Mountain Care Board is currently working on. Act 55, as I mentioned, capped the drug charges. There were other changes to our regulation of accountable care organizations in Act 62. Act 49 put in a very important provision that was a safeguard in case of insurer insolvency, gave the Green Mountain Care Board the ability to adjust rates in the event of a potential insolvency. And then Act 15 was an effort to update our CON rules to make it make it more accessible for smaller businesses to enter our healthcare space.
Questions? We're moving in the right direction is what I'm hearing you say from the
100%.
perspective.
Yeah.
And from a regulatory environment, this is important to us. So keep us posted. I know there are things that you'll be asking for during this session. We'll take a look. Thank you.
Okay, thank you.
And we have retaining accountable care organization capabilities. We have a report on that. Is Jill doing that report?
Yes. She just said, yeah.
You sit down here. Let's take a short break offline.
That sounds good.